So welcome to the University Seminar Series hosted by the GW Institute for Brain Health and Dementia. The topic for this series is addressing dementia across the public health spectrum. This is the second lecture in a special subtopic of biological mechanisms of dementia. We're very fortunate today to have Dr. Jennifer Deal as our speaker. Dr. Deal is an epidemiologist and gerontologist with expertise in hearing loss and cognitive aging. She is an assistant scientist of epidemiology and otolaryngology, head and neck surgery at the Johns Hopkins University, and core faculty and associate director for academic training with the Johns Hopkins Cochlear Center for Hearing and Public Health, a first-in-kind research center dedicated to training a generation of clinicians and researchers to understanding and address the impact of hearing loss on older adults in public health. Dr. Deal completed an undergraduate degree in biology from Indiana University and received Master of Health Science and Doctor of Philosophy degrees from the Johns Hopkins Bloomberg School of Public Health. Trained in the epidemiology of aging, Dr. Deal studies how hearing loss and vascular factors impact the aging brain and cognition to provide insight into mechanistic pathways involved and to inform development of public health prevention strategies. Her topic today is titled Hearing Loss in the Aging Brain. So please take it away, Dr. Deal.
Thank you so very much, Dr. Cole, for the introduction, and thank you very much, Dr. Power, for the invitation to be here today. I'm delighted. I'm going to go ahead and share my screen, and I also have the chat. I'll pull the chat up. So if there's any questions that come up during the talk, please feel free to post them as we go, and I'll kind of be monitoring that. So I love talking with groups who know already about dementia and brain health. So I'm not starting with the importance there. I think we all understand the importance. Instead, I want to talk a little bit about what we know about the relationship between hearing loss and dementia. So starting with the Lancet Commission report on dementia prevention, intervention, and care. This was first released in July 2017 and then updated in the summer of 2020. And from that updated report, they looked across all potential modifiable risk factors for dementia and kind of estimated the proportion of dementia risk attributable to each factor. And what they concluded was that hearing loss may be the single biggest modifiable risk factor for dementia. And so they estimated that the proportion of risk for dementia due to hearing loss in the world is about 8%. And so the interpretation of this is that 8% of dementia cases in the world could be due to hearing loss and could potentially be prevented if no one had hearing loss, either because we're able to effectively treat hearing loss or we're able to prevent hearing loss from occurring in the first place. This is a wonderful statement. It has a lot of public health relevance, but it does have also a lot of strong caveats in terms of the interpretation. So it assumes all the studies that we use to estimate this 8%, there's no confounding or bias. We know that's not the case. Of course there is. But maybe even more importantly, it assumes that hearing loss causes dementia, and we don't yet know if that's the case. We have some studies ongoing that may give us an answer, but right now we don't know. And so I do just want to pause and start by talking a little bit about why hearing loss ranks this way. Why is that number so high compared to other risk factors? And so the first reason is that hearing loss has a really high prevalence. It impacts a lot of older adults. So this is data from our group. It's from the nationally representative National Health and Nutrition Examination Survey. We have the prevalence or the proportion of individuals who are impacted along the y-axis. And then we have age groups here along the x-axis. And you can see as we increase in age category, the prevalence of hearing loss increases really dramatically. And so it's 2/3, 2 out of every 3 older adults who are 70 years or older in the United States have a clinically significant hearing loss. And by that, I mean it's a hearing loss that is severe enough that it could impact their everyday communication and their everyday quality of life. So because hearing loss is so prevalent, that's one of the reasons why it has such a high population attributable fraction. The other reason is what we know about the relationship between hearing loss and dementia. So there were only 3 studies, so that is a limitation of the Lancet, report, but there were only 3 studies included. But of those 3 studies, the average relative risk for the association between hearing loss and dementia was 1.94. So an estimated 94% increase in the risk of dementia among those who had hearing loss compared to those who did not. So a strong association as well. So those 2 things coupled together are really why we see that high 8% population attributable fraction. I'm just showing here as well. So that was a systematic review and meta-analysis for the association between hearing loss and dementia in older adults. There have also been a number of studies that have looked at hearing loss and cognitive performance and cognitive decline. And this is just one of the systematic reviews, and this is specifically looking only at prospective studies. But the authors found when they summarized all of the studies that had looked prospectively at hearing loss and cognitive decline, that there were associations across a large number of domains, all of the domains that are shown here. So attention, delayed recall, fluency, global cognition, immediate recall, and so on. So overall, the evidence suggested that there was a faster rate of decline among those who had hearing loss compared to those who didn't. So there is quite a bit of evidence that exists that shows that there's an association. And what I haven't really talked about yet, but what I want to focus a little bit more on now is thinking about why. Why do we see this relationship between hearing loss and dementia and cognitive decline? And so the first possibility is that there's some common cause, and this could be something relating to aging, maybe inflammation or vascular factors that are leading both to hearing loss as well as to the dementia. This is an important consideration for us to think about. I'm going to return to it a little bit later in the talk. So acknowledging that a common cause certainly could induce an association between hearing loss and dementia, I want to instead start by really focusing on some of the direct pathways by which we think hearing loss may actually cause dementia and cognitive decline. So it's not just a correlation, it's not due to some common cause, it's actually a causal factor in dementia and cognitive decline in that pathway. And so the first possibility is something that we call cognitive load. And so, to simplify a little bit, but not too much, when we think about hearing, it actually occurs in 2 steps. So the first step is sound enters the ear, it goes to the inner ear. In the cochlea, which is that snail-shaped organ, it is transduced, that sound is transduced, the mechanical sound is transduced into a neural signal. That neural signal is then sent to the brain where it's processed. So we can think about encoding of the sound in the inner ear, that's the first step, and then decoding of that signal in the brain. That's the second step. When we have cochlear impairment, so that means the cochlea is not functioning as well as it used to. This occurs with aging as well as with some disease. What that means is that there's decreased sensitivity. And when the sound is encoded, it's distorted. So instead of being a crisp and clear signal, it's more of a garbled signal. And so it's not so much a question of amplification, it's a question of really being able to understand that garbled sound. And so that distorted sound, that distorted signal when it's sent to the brain, it just means the brain has to work that much harder to decode that signal. And that potentially could come at the cost of doing other things like forming a memory, for example. And this is something that has been widely regarded in the auditory literature and in the auditory neuroscience literature. And it's been coined effortful listening, which I think is a nice way to explain it. So if you have had an experience maybe with an older loved one or an older friend who has some hearing loss, again, it's not an all or nothing phenomenon. It's just that the signal is garbled. So they may say things like, speak up, it sounds like you're mumbling, that sort of thing. So their brain is just having to work that much harder to process that distorted signal. Another potential mechanism is by increasing social isolation or loneliness. So social isolation is the objective measure of the number of social connections we have in our life, for example. and the quality of those connections. And then loneliness is the subjective measure about how we feel about that. And certainly they're correlated, but they don't have to go hand in hand. So someone may have a relatively small social network size, but feel that the quality of those connections is really high and not experience any loneliness. By contrast, someone can have a lot of connections, a lot of friends and family members, but if they don't feel the quality is very high, they may feel very lonely. So there have been studies that have looked both at that objective measure of social connection as well as with that subjective measure of loneliness. And here on the top is Allison Wong. She is a PhD candidate in the Department of Mental Health at Johns Hopkins, and she is one of the center trainees at the Cochlear Center for Hearing and Public Health, where I work. And she looked in the National Social Life, Health, and Aging Project and found that people who self-reported fair or poor hearing compared to people who reported excellent hearing, that was associated with the 50% increase in the odds of loneliness. And then we also had a trainee down at the bottom, Aishwarya Shukla. She took a year off to get her MPH degree while she was pursuing her MD. She now has both degrees she's completed. But she was interested also in this question. And so she conducted a systematic review of the literature and found that hearing loss was associated with loneliness. Now, the caveat with that is there were only 14 studies, and 12 of those 14 studies were cross-sectional. When I talk to my colleagues who see individuals with hearing loss in the clinic, they will often tell me that they see this as a consequence of the hearing loss, that individuals are talking about how they're not able to engage socially in the way that they used to, or that they're feeling lonely. But they're really, my take on the literature is that we really still have a long way to go. So anecdotally, clinically, we definitely see this, but certainly those feelings could be driving people to seek care. And when we look in the literature, there are some studies, but I think the quality of those studies is relatively low. And so I do think that this is an area where there's a lot of work ongoing now to try to understand at the population level, among everyone, not just those seeking care, is hearing loss associated with increased loneliness and isolation. And then finally, a direct pathway by which hearing loss could lead to dementia and cognitive decline is through direct changes to the brain structure and function. And this is something our lab is particularly interested in understanding. So when we think about the brain, we understand that there are certainly pathologies that become more common as we age that can impact our cognition and thinking abilities. Cerebrovascular disease, for example, certainly Alzheimer's neuropathology. And the hypothesis here is that hearing loss is independent of these, but it's something that if you have, in addition to these other conditions, these other pathologies, that may be just enough to push you over the edge so you're no longer able to compensate, and that really may start you on a trajectory of decline, ultimately perhaps leading to dementia. And there have been a number of studies, and again, this is more from an auditory neuroscience perspective or a number of individuals more from a psychology background, looking at the relationship between hearing loss and what happens in the brain. So we know from these studies that poor hearing is associated with reduced activity in the primary auditory pathways. I think that's not surprising. So if we no longer have the input coming in, then those parts of the brain that used to process that input just may not be as active as they used to be. I think that's not surprising. But what's interesting and what's been shown in several studies is that actually there's increased compensatory activity in the prefrontal cortex, specifically in the dorsolateral areas, which may indicate that older adults who have difficulty hearing are recruiting additional portions of their brain to help with that problem solving, to help with that decoding of that distorted signal. So there, we don't exactly know what this means, but it is at least a pathway by which we know that hearing loss could impact parts of the brain outside of that primary auditory cortex. And we've looked in a couple of cross-sectional studies at the relationship between hearing loss and brain volumes and white matter integrity. So James Ting was a medical student, took a year off to do some research with us. And he was interested in the relationship between hearing loss and brain volumes. And so we used data from the Atherosclerosis Risk and Community Study, or the ERIC study. It's a population-based prospective cohort study. It's been going on since the late 1980s. 4 study sites around the United States. And what he found was cross-sectionally that hearing loss was associated with smaller volumes, brain volumes, in the superior temporal gyrus, but not anywhere else. That's not, again, surprising, because that's where the primary auditory cortex is located. So that might be where we would expect to see smaller volumes among those with hearing loss. And then Pauline Kroll, who completed her PhD in epidemiology from Erasmus University while she was a student, she came and did a visiting fellowship with us. And she was interested in the same question, but about the white matter microstructure. And so she looked at white matter integrity as measured with DTI, diffuser tensor imaging. And what she found was that there were hearing loss was associated with poor white matter microstructure in the temporal lobe, again, that same area where the primary auditory cortex was found, as well as in the limbic tracts. And this is using the same data set. So we have evidence for both smaller brain structures as well as for poor white matter integrity associated with hearing loss. And so those were 2 cross-sectional studies. You know, there are a number of people who have been interested in this, and I think this is still probably one of the strongest studies that's been conducted in this area, because it's prospective with about 10 years of follow-up. So this is data from the Baltimore Longitudinal Study on Aging. It's the longest running study on aging in older adults in the United States. Looking at annual rates of brain volume change over time, there were 126 participants. Age range was from mid-50s up to about 86. Annual MRIs, again, over about 10 years with a mean follow-up of 6.4 years. And then looking when we compared individuals who had hearing loss compared to those with normal hearing, it's the temporal lobe, again, that stands out in terms of a faster rate of atrophy over time. And then when we look particularly at the different regions, so now within the temporal gyrus, the superior, middle, and inferior gyri, we see actually associations across the board. And so this is important. These areas, particularly the superior temporal gyrus, that's where the primary auditory cortex is. We know that area of the brain is responsible for sound and speech, but also, you know, these other areas are associated with memory and with sensory integration. And I don't think I specifically mentioned it, but in Pauline's study looking at the white matter microstructure, she found differences across all regions in the temporal lobe as well. So there is some evidence to suggest not only is hearing loss associated with reduced volumes cross-sectionally, but also with faster rates of atrophy over time. And so those are kind of the 3 primary causal pathways by which we think that hearing loss could lead to dementia or cognitive decline. And I now just want to return again to this idea of the common cause. And one common cause that's been discussed a lot by those who study this is really the contribution of vascular disease and potentially systemic vascular disease. So the cochlea is actually the most metabolically active organ in the body. It has something called the striatus vascularis, which has a lot of blood flow supply needed to fuel that cochlea as it's working. And so there have been a number of studies that have looked at things like diabetes and hypertension and whether or not they're associated with increased risk or increased prevalence of hearing loss. And we've looked at some of these questions too. So again, James Ting, during his research year with us, looking at the relationship between hypertension and blood pressure patterns over time and their relationship with hearing loss. So again, this was within the ERIC study. And we now had a lot of follow-up time. So by which we could look at patterns in blood pressure in midlife and its relationship with late life hearing loss. And so compared to those who had persistent normotension, those who had persistent hypertension over mid to late life, they had worse central processing. And so there's a specific test I didn't mention that we use to kind of understand what's going on in the brain in terms of the processing. There are different tests you can use. One that we use is a speech and noise task called the quick speech and noise. And so that's where we found a difference. So we found that persistent hypertension was associated with poor speech and noise, a measure of central auditory processing, but it was not associated with what is happening in the auditory periphery. So with the pure tone audiometry that we had. So that's interesting. From that, we really interpreted, that we know that hypertension is associated with brain health. And certainly we're seeing that here too. The Quixin is a measure of brain health as well, but we didn't see associations with the ear. So association with the brain, not with the ear. And then Julie Kim, now married Julie Yee, when she did some work with us, she's currently an MD student at Hopkins. Again, we used data from the ERIC study. She was interested in looking at retinopathy as a risk factor potentially for hearing loss. And she did find a small association, but it was in a small number of individuals, only in a subgroup analysis that was kind of post hoc, 42 individuals without diabetes. So it did look like there was a small relationship there, not terribly strong. But again, we have to worry a little bit about the interpretation and inference from this study because it was a post hoc subgroup and a small number of participants in that subgroup. So a great question from Jerry in the chat, Jerry Franz. How is hearing loss measured by scientists in these studies? Is the method consistent from study to study? Thank you for asking that, because the answer is no, it's not consistent. And certainly I think the way in which hearing is measured can make a big difference. So the studies that I've really been talking about, for the most part, there was only one. So Allison Wong's study on loneliness used self-report hearing, but everything else has been measured with audiometry. So audiometry is the clinical gold standard. It determines the faintest sounds that an individual can hear across a variety of pitches. And the pitches that we're really interested in are the ones that are most commonly needed for speech. And so depending on which study you're reading, because we can measure thresholds, hearing thresholds across a variety of frequencies, different people may define it in different ways, but oftentimes people will use what we call a 4-frequency pure tone average. And so this is where you take the threshold at 0.5 kilohertz, 1 kilohertz, 2 kilohertz, and 4 kilohertz. And again, the reason why we choose those is because those are the frequencies that are really important for speech. And 4 kilohertz is something that in common with age-related hearing loss, that's the higher frequencies tend to go first. And we include that one as well, also important for speech. So we tend to do an average of those and look in the better ear, because that's a little bit maybe more conservative and also a way for us to kind of gauge in your real life if you have asymmetry, which some people may have, for example, from firearm use. If there's asymmetry, but so you can still hear well out of one ear, but maybe not so well out of the other ear, then hopefully, you would be able to compensate a little bit with the better ear. So we tend to use a better ear for frequency pure tone average. But not all studies measure that way. There are a lot of studies that use self-report, which I think has value, but also does not directly correlate with the audiometric measures. Thank you for that question. Yeah, so I mean, I certainly do think vascular disease is contributing to age-related hearing loss. I think its impact is relatively small compared to other potentially modifiable risk factors. Probably the greatest modifiable risk factor would be noise exposure. And then certainly there are non-modifiable risk factors for hearing loss: age, race, ethnicity, and sex. And so those things are really contributing. I think vascular disease is, but probably not to the extent that it's likely to explain all of the association between hearing loss and dementia and cognitive decline. And I think another common cause that some people have explored a little bit, and we have as well, is, what's the nature of the relationship between hearing loss and Alzheimer's pathology? I started out by saying that I thought it was really probably that these pathways were independent, that hearing loss is this additional hit in addition to the Alzheimer's pathology. But there have been some people who have worried that, what's going on in the brain is actually impacting our ability to hear, and that's why we're seeing this association. So we and some other groups have looked at the relationship between hearing loss and beta amyloid in the brain. So this again is from the Atherosclerosis Risk in Communities study. This is a cross-sectional analysis. We had floor beta peer PET in about 250 individuals who also had hearing measured. And what the graph is showing here, it's the mean values of that pure tone average that Jerry asked about. So it's those mean values broken down by race and by sex. The light gray bars means that amyloid was absent in the brain. The darker gray bars means that it's present. And so you can see, regardless of kind of which group we're looking at, the mean hearing thresholds are about the same, regardless of the group. And so, and regardless of amyloid, whether amyloid was present. And when we actually modeled this in a fully adjusted model, the prevalence ratio for every 10 decibel increase in hearing loss was just about as null as you can get. So it was 0.99. The null value is 1, suggesting no association. So we did not see an association between hearing loss and amyloid in this study. There have been other studies that have replicated this finding as well. So I really don't think it's through this kind of direct relationship with the Alzheimer's pathology leading to hearing loss. I think instead it probably is through these neurodegenerative pathways. If hearing loss has an impact on the brain, that's where my money is, and that's what's happening. So to kind of summarize so far, hearing loss is associated pretty consistently and also pretty strongly with dementia and cognitive decline in a large number of observational studies. And then those number of studies just is continuing to grow. There are a lot of people interested in this topic now. We do think that hearing loss may be linked to dementia and cognitive decline through several causal pathways, and those causal pathways potentially include increases in cognitive load, changes in the brain structure and function, and increases in social isolation and loneliness. All of the results I've shown you so far, and certainly many in the literature as well, adjust for a variety of demographic and health factors. I think it's unlikely that the entire relationship, given the strength, is explained by all of those factors too. So where does that lead us? So that's a little bit talking about, confounding. I don't think probably confound is explaining all of the relationship. But we know in order to be able to interpret this 8% in a way that's meaningful for public health prevention, there are some other caveats that we have to explore too. So not just confounding, but additionally bias. We need to make sure there's no additional bias in our studies that's influencing kind of the estimate of the relationship between hearing loss and dementia and cognitive decline. And so I was interested in pursuing this in a little bit more detail. I worked with a close colleague of mine, Dr. Bonaline Sweenor. So she is an associate professor of ophthalmology at Johns Hopkins University. And she also is the director of the Disability Health Research Center. And so we had a grant where we wanted to understand this potential link for bias, and particularly in the way that sensory loss may impact how we measure cognition in older adults. So for those of you who are involved in data collection, neurocognitive data, you know that the way we measure this is either on paper, so we give the individual a test that they have to complete, or it is by reading something out loud to them and then asking them to respond to us based on what we've said to them. So cognitive tests that are administered orally are on paper. And when we're talking about people, older adults who have sensory loss, hearing loss, and vision loss, the question we wanted to understand was whether the mode of administration for these neurocognitive tests could actually result in biased estimates of cognitive performance among older adults with sensory loss. And so just kind of, a quick conceptual framework, when we think about people who have hearing or vision loss, what we can actually measure is their performance on the neurocognitive tests, but we know that's associated with their underlying cognitive function. So hearing or vision loss, we think is impacting directly through some of those causal mechanisms that I discussed. We think it's directly impacting poor cognitive function, and then we should be able to measure that using our neurocognitive tests. One potential source of bias is a selection bias. So selection bias is where there's a distortion of the measure of association, so our relative risk or our odds ratio, from the truth. And it's based solely on the way that people were included or excluded as part of our study sample. And so one particular concern that we had is that the participant may choose not to complete cognitive testing, or some studies may choose to exclude individuals from testing because of their sensory loss, because they are concerned that that may impact how well we're able to measure. So that was one particular type of bias we were interested in exploring. And there were a couple of possibilities for hypotheses here. So if someone were to choose not to complete cognitive testing, it may be that someone with hearing loss, if hearing loss is causally leading to cognitive decline or dementia, on average, then individuals with hearing loss may have lower cognitive function. And then if they have lower cognitive function, that may lead them to not complete the tests, right? So people with hearing loss may be more likely to fail to complete testing because hearing loss is associated with cognitive decline, and cognitive decline is associated with less completion of cognitive tests. And if that's the case, then the assumption, the hypothesis might be that missingness on these tests is greatest for tests that are specifically related to those domains that we know would be impacted by hearing. So based on the mechanisms I presented before, it's really memory and executive function that we anticipate would be most impacted. And then the second possibility we worry about is that people with hearing loss may not complete testing, but it's just because they can't hear. And this is really the hypothesis that's been put forward in the literature, that some individuals, when they have hearing loss, when they're getting their cognition tested, if the hearing loss is not accounted for, they may not be able to hear the testing stimuli, then they may not respond, they may score lower. And what we're measuring in that circumstance is not actually their cognition. Instead, we're measuring their hearing. And so that's the concern. And if that's the case and that's what's happening, then it may be that the most effective tests would be those that have that auditory only administration. So there's no written component. It's just when I talk to you, that we might anticipate people with hearing loss would be less likely to complete more often compared to people with normal hearing. And so to evaluate this, we again went back to the atherosclerosis risk and community study. This was a cross-sectional study. We used pure tone audiometry to define our hearing loss. Our final sample was about 3,580. We had 10 neurocognitive tests as our outcome, and then again, our exposure was hearing, measured through audiometry. And here, this is a very busy slide, but it's just meant to show you overall patterns. And it honestly is meant to be a little bit overwhelming because the number of individuals who had missing tests was pretty amazing. So 23% of all of the participants did not complete at least one test. And then what's showing here in this graph, all of the individual tests are on the y-axis, and then the pattern and the number of individuals who have each pattern is what's on the x-axis. So you can see there are actually 89 different patterns of ways in which people completed or did not complete all tests. The most common, happily, was that everyone completed everything. But there were a number of tests that had high levels of missingness across the board. And one of those was the trail making test part B, which overall for the entire sample, 17% of participants did not complete that test. And so when we look at the relationship between hearing and the prevalence of missing data on these cognitive tests, I'm presenting here only the findings we found that were significant, statistically significant. But for logical memory 1 and 2, it was about a 20% increase in the prevalence of missingness, comparing individuals who had hearing loss compared to those with a 10 dB better hearing. Boston naming test, again, was similar, and digits backwards, again, a similar proportion. And then trail making test also we saw as well, trail making test part B. And I'll just point out here, 3 of these tests, and they were the only 3 tests that were completely an auditory only administration. They all had higher prevalence of missingness for people who with hearing loss compared to people without. But also there were a couple of pen and paper tests that stood out too, including the Boston naming and the trail making test part B. And so for those of you who know the trail making test, was developed in the 1940 for the US Army. There are 2 components, trails A and trails B. A is really considered a test of psychomotor speed. You're asked to put, this is the test grid, and you're given an example grid and a practice grid ahead of time to make sure that you understand the instructions. But for the actual test, you're asked to put your pen on number 1, and you're asked to not pick up your pen or pencil, to just keep it on the paper the entire time. And then as quickly as you can to connect the dots in increasing numeric order. So you start from 1 to 2, then to 3, then to 4, then to 5, then to 6, 7, and so on. So it is a time test. And their shorter times, smaller times are better because you're completing it faster. Trail making test B is a lot harder. So B, instead of actually just increasing in terms of the numeric sequence, now we're adding in letters. So it's increasing alphanumeric sequence. And so this is really considered more a test of executive function. It's something called set shifting, where you have to be able to understand, I'm starting at 1 and now I'm switching to the letters, and then I'm switching back. You have to be able to inhibit that natural response to move on from 1 to 2. You have to be able to stop yourself and say, no, I need to go to A. So this test actually is quite a lot more difficult. So you start it on 1, 1A, 2B, and I never know where B is, and so on, 3C, and so on, until you complete. And so Trails B was the test where we saw a lot of individuals not completing. Trails B is a tough test, and it comes at the end of the battery. And I think that's partly why we saw an increase in the prevalence of missingness among those with hearing loss. I think that they were probably tired, fatigued by the time they got to this part of the battery. And so we saw this higher prevalence of missingness on some cognitive tests, but then we were interested in understanding how that level of missingness would impact our findings. So our overall research question of interest is, what's the relationship between hearing loss and cognitive performance? And so we understand that people with hearing loss are less likely to complete testing. If we just ignore that and do a complete case analysis, what are our findings? So that's what we did at first. And I'll just make sure to emphasize, we're now looking at a summary, a Z-score of all the neurocognitive tests, except those that were auditory only administration. So this is looking at tests that were at least had some sort of visual component. So we're trying to get rid of that potential frank confounding by hearing loss. So it's only among those tests that at least had some visual component. And what we find is that hearing loss is associated, even among these tests, with poor cognitive performance, on average 0.2 standard deviations lower for those who had a moderate hearing loss compared to normal hearing. And that's when we ignore the missing. One of the great amazing things about ERIC as a data set is that we have a lot of auxiliary cognitive information. So if you didn't come to the visit, we have a lot of proxy information that we gather. We have cognitive data from prior visits. So we're able to use all of that extra data to kind of impute what the value would have been using multiple imputation had you actually potentially completed the test. So when we don't ignore the missing, instead where we say we think the missing is informative and we're going to impute for that missing cognitive data. These are our findings. So we see that the estimates strengthen across the board, not a lot, but by something that's meaningful. So here it strengthens from 0.2 standard deviations to 0.28. We even also see kind of an inference change where before mild versus normal hearing, there was a suggestion of association, not statistically significant. Now it's strengthened and we do see a statistically significant difference. So actually what we found was that ignoring that missing data underestimated the relationship between hearing loss and cognitive performance in this sample. So kind of summarizing that, we really need to make sure we're measuring cognitive impairment in the right way. We need this for observational studies, from observational studies in order for public health planning. We need it to understand risk factors for dementia and cognitive decline. But what we found is that people with hearing loss were less likely to complete cognitive testing compared to people without hearing loss. And actually, that's a large proportion of the individuals, just like we talked about before. It's 2 out of 3 older adults over the age of 70. And not only that, when we ignored that missingness, we actually underestimated the relationship between hearing loss and cognition. And that's in contrast with some hypotheses others have put forward that have said, look, you're going to be overestimating the amount of cognitive impairment among individuals with hearing loss because they just can't hear the tests. That's actually not what we found. So, selection bias, certainly there may be other ways for selection bias to influence our findings. At least here, we did not find that selection bias would be explaining the association. If anything, it would be underestimating the association based on our findings. And then in addition to selection bias, another important type of bias we were interested in exploring was that related to measurement. So measurement error, when we think about there's this underlying latent trait of cognitive function. This is what's true. It exists in the world. We have a measure of that in our cognitive test performance. And so we were concerned if the measurement of cognition, this underlying latent trait, differed by sensory loss based on the way that we were measuring things, that could induce a bias, a measurement error bias. And so just to kind of quickly describe that, when we think about how we measure cognition, think about that neurocognitive test, for example, TRAILS-B, that test should measure cognition, right? It should, that's the whole goal, but it should also measure cognition the same way in different subgroups. And so it should measure cognition in the same way in people who have hearing loss compared to people who have normal hearing. Or it should measure cognitive function in the same way across different race and ethnicity groups, for example. So cognitive tests, we want to make sure it's measuring things the same way in those with and without hearing loss. Otherwise, there's measurement bias. And the way that we can try to understand whether measurement bias may be present is by estimating something called differential item functioning, which is also called DIF. And so for this project, we worked with Emma Nichols, who's currently a PhD candidate in epidemiology at Johns Hopkins, and with Alden Gross, who's an associate professor of epidemiology, who has a lot of expertise in measurement theory. And so we were interested in assessing differential item functioning. We used a couple of different data sources. One, again, was the Atherosclerosis Risk and Community Study, and one was the Baltimore Longitudinal Study on Aging. And so using these IRT methods or item response theory methods, the question that we're really trying to get at is, are those scores that depend on hearing different among those with hearing impairment after we're controlling for underlying cognition? So that was the question we were trying to address. The figure on the right is just showing that we had a lot of different neurocognitive tests from both studies that we were able to look at both hearing and vision. And so what we found was that there was diff in some tests. So for hearing, we found diff for the digit symbol substitution task in the Baltimore Longitudinal Study on Aging, and with an incidental learning test in ERIC. For vision, we found diff in delayed word recall. And, one of the hypotheses may be actually related to cognitive load again, which would also potentially fatigue may play a role for vision as well. So could this be reflecting that there's increased cognitive load, increased fatigue, and so the neurocognitive tests aren't performing quite as well after controlling for underlying cognitive function? But I will just point out, so the box and whiskers plot here on the right is comparing a difference between the diff adjusted scores and the non-diff adjusted scores. And the down here, 0 means that there's no difference between the scores. And so you can really see that there really wasn't much of a difference when we adjusted for diff and when we didn't adjust. And so the interpretation from that is actually like, is the difference we saw this diff, is it clinically meaningful? And the answer is probably no, at least not in these studies. And so clinically meaningful diff is sometimes called salient diff. And so that's what we were addressing here. So I think the jury's still out. I think ours is the only study that I know of to date that has looked at this question. I think we could certainly look in other cohorts. We did see the suggestion that there were some differences after controlling for underlying cognitive function, but maybe they weren't that strong enough to actually be clinically significant. So there's a yellow X on that line there because I think there's more work that we can do in this area as well. And so I think I'll just kind of wrap up here by talking about some of the big picture unanswered questions in this space right now. And probably the biggest one is the impact of treatment. So there have been a lot of observational studies that have looked at whether hearing aids help prevent cognitive decline, help delay onset of dementia. I'll say that all of them are consistent. So we are seeing that in the observational literature. But it's very tricky because the way in which hearing healthcare operates, at least currently in this country, is that hearing aids are often an out-of-pocket cost. There's a lot of navigation through the healthcare system that has to happen. You have to get medical clearance from an ENT. You're seeing an audiologist. You're probably going back to see an audiologist or a hearing aid dispenser, 4, 5, 6 times to get the hearing aid fit. And so really when we look at individuals who use hearing aids versus don't use hearing aids, there are big differences in those groups. So hearing aid users tend to have higher education levels, they tend to have higher socioeconomic status, greater utilization and access to healthcare. And all of these things we know help protect against dementia and cognitive decline. So because these groups tend to be so different in our observational studies, it can be really difficult to disentangle what's the impact of the hearing aid versus what's the impact of all of these other factors. And so that has really argued for us the need for a randomized clinical trial for this. And so that's what we're actually in the process of conducting right now. It's called the Achieve Healthy Aging Study. The MPIs on this trial are Frank Lin, who's the director at the Cochlear Center for Hearing and Public Health, as well as Joseph Korish, who's a professor of epidemiology at Johns Hopkins. And so we have 977 participants. The age range was 70 to 84, untreated mild to moderate hearing loss. We randomized them 1-to-1 to receive either a hearing intervention, and that included amplification with free hearing aids, as well as a lot of rehabilitation strategies. It was really heavily focused on meeting the hearing goals and needs of the individual. So they were randomized either to receive that intervention or to receive a health education control. And so we're following them for 3 years. This study, interestingly enough, is nested within the ERIC study. So we have some ERIC participants as well as some participants we recruited de novo from the surrounding communities. And then we were delayed a little bit by COVID, but we have continued with data collection. And so originally we thought we'd have results next year. I think now it's safe to say we'll have our final trial results by 2023. So hopefully this will be able to tell us whether hearing aid use among those with untreated hearing loss, older adults, can actually help delay cognitive decline. We talked a little bit about concerns about the measurement of cognition and those neurocognitive tests. I think still thinking about that, what are the best practices for how we measure cognition in older adults? Maybe there's some measurement error, maybe not, some more work to do there. Um, but this was also a question we were interested in as part of this grant, Dr. Sweenor and I. So if we want to know what best practices are, we wanted to make sure that we started by saying, well, what's the current state of what's happening right now, and summarize that a little bit as well. And to date, we're not aware of any formal analyses of protocols for collecting neurocognitive data in older adults, and how sensory loss is handled. So that's what we set out to do. And we had help with this. So Chelsea Liu, who is pictured on the left, was a master's student at the time. She's now a doctoral student in epidemiology at Harvard. And then Nini, who's pictured on the right, postdoctoral fellow at the Johns Hopkins Dana Center for Eye Care. And so we did a systematic review, but the point of the review wasn't trying to find, oftentimes when we do a review, we're interested, for example, in what's the relationship between hearing loss and dementia. So we'll find every study that meets our inclusion-exclusion criteria that has tried to address hearing loss and dementia. We had a slightly different question. We were interested in understanding the parent studies. So how many cohort studies out there are collecting cognitive data in older adults? So that's really what we were interested in doing. We restricted to a prospective design. We wanted to have at least 200 participants to really kind of focus more on the epidemiologic literature rather than the clinical literature. Older adults, so mean age 60 years or greater. At least 2 neurocognitive tests collected, so we wanted cognition to be an important component of the study. And then we wanted it to be published within the past 10 years because we administered a survey to all of these parent studies. And so what we found, starting with over 82,000 individual records that were identified, after the duplicates were excluded, we had about 25,000 records. There were a large number that did not meet our inclusion criteria. So we had 898 for a full text review. Of those, then we were removing duplicate studies from the same cohorts because we were only interested in those unique parent studies. So 228 unique cohort studies were identified. We weren't able to contact 36 because we didn't have contact information for them. But of those, whatever 228 minus 36 is, not quite 200 studies, we administered a survey or requested a survey of those studies to understand if hearing and vision was considered as part of their neurocognitive data protocol. And we had responses from 85 total studies. And what we found overall is that there was variation among those studies who responded. Good news is I think a lot of studies were considering this. So they were measuring hearing or vision in some way. 88% of the studies assessed both. But how hearing and vision were measured varied by study. So 38% measured hearing objectively, 53% measured vision objectively. Objective measures take a lot more time. So certainly that's a consideration, I'm sure, when developing the protocols for these different studies. And then how hearing and sensory loss were considered as part of the studies also varied. So 22% offered accommodations for hearing loss, something like amplification like a pocket talker, and 38% offered accommodations for vision loss, so something like, large text tests. And so I think just broadly in terms of considerations when we want to think about moving towards best practices for collecting neurocognitive data among older adults with sensory loss, we know there's a lack of standardization based on the work that we've done. And one comment that I'll make, and we've been thinking a lot about, is we tend to exclude, or at least in the past, we've tended to exclude out of concerns that we wouldn't be measuring cognition well among individuals with sensory loss, right? If they can't hear the test, we're worried we're not actually measuring their cognition. But that kind of frank exclusion is really not equitable. So we have a lot of older adults who have sensory loss. From a health equity and a social justice perspective, which is really starting to integrate its way back into public health and into epi work nowadays, right? It means that we don't have information which we can base policy and clinical decision making, right? If we're excluding those individuals, then we don't know about the nature of the relationship, and that could definitely influence these downstream translation of the findings. So it's really important that we make sure we include individuals with sensory loss in our studies. And we can do that in a variety of ways. So we can offer accommodations. And then, some studies will offer individual level accommodations. Sometimes those are accepted, sometimes they're not. So if an individual does not feel like they have hearing loss, or if they're concerned about stigma, or they may feel a little bit embarrassed, they may not accept a pocket talker. Versus if you just had a pocket talker available for everyone, that's a universal accommodation that just may make things a little bit easier in terms of data collection. But it does really depend on the research question. So if you're interested in the relationship between hearing loss and cognition, I would argue that you should not use amplification, that we want to understand how individuals are performing in their everyday life. So that's important to keep in mind as well. And so ultimately, just understanding the nature of the exclusions and the accommodations that are offered. Right now, we're really limited in word count, but I think we really need to make a plea to our journal editors. That's important information that needs to be included so that we understand who is included and who is excluded from cognitive testing. I also think another really important question that hasn't yet been addressed is, are there differences by important subgroups? So by geographic location or by race ethnicity? Those 3 studies in the Lancet Commission report I cited were all high income countries, 2 in the United States, 1 in the UK, primarily white populations. And there have been, so the Lancet Commission also looked not just globally, but breaking it down by region. So on the left is Latin America, in the middle is India, and on the right is China. And because the prevalence of these risk factors varies in the different locations, we see very different population attributable risks. And we're seeing that early life low education is very important in these settings compared to something like hearing loss, which has a less of a population attributable fraction. So I think there's a lot more work to do here. Currently right now, we really don't understand if there's differences by race, ethnicity, or by sex, or by other important subgroups that could help drive identification of high-risk groups for intervention potentially. And then finally, I think gaining a lot more traction is the impact of both dual sensory, so both hearing and vision, but also multisensory impairment. So people are starting to think much more broadly rather than looking at senses in isolation. And we've done a little bit of work in this as well. So this is data from the National Health and Aging Trends Study. It's a nationally representative study of Medicare beneficiaries in the United States. Prevalence of sensory loss, vision only is the dark bar, hearing only is the middle kind of blue bar, and then the lighter bar is dual sensory loss, both hearing and vision. Among people age 60 to 65, dual sensory loss impacted about 1.4%, but that increases with age really dramatically. So among those who are 90 years or older, it was 15%, so 1 in 7 individuals. And when we looked at the risk of dementia over 7 years, dual sensory impairment compared to no sensory loss was associated with about a 50% increase in the risk of dementia over time. So we're coming to the end, and I'll just conclude here. When we think about healthy aging, we tend to think about function like cognitive function, physical function, social function. All of those things are really important, and they all depend on our brain. But the way that our brain interacts with the world, our environment, is through our senses, right? It's completely encased in our skull. It's not directly interacting, it's through our senses. And so it really is, I think, increasingly recognized that healthy sensory function is probably important for healthy aging as well, across all these other different types of function too. And so if anyone is interested more in this topic, I invite you to join us. To this end, we have created something that we call the Sense Network. This is an international group. We're supporting research that's related to sensory loss across all senses: vision, hearing, olfaction, touch, and taste, as they relate to health and aging. And our website is here. So with that, I just acknowledge funding as well as a lot of the co-authors on all the work here presented. And I know we have just a couple of minutes, but I'm happy to take any questions at this time. And I have the chat up, so please feel free to put any questions in the chat. And I'll also go ahead and stop sharing so that if you are comfortable turning your camera on or would like to turn your camera on to ask a question, that's a possibility too. So thank you.
I guess I'll ask a question out loud if that's okay.
Sure.
So this might be too entangled into progression of hearing loss, but is there a relationship between duration of hearing loss at different stages and cognitive decline and brain function?
That is a fantastic question. So unfortunately, we're limited in a lot of the epidemiologic data sets that have hearing loss measured. Usually it's just at one point in time. And so we're able to look kind of at the relationship between maybe people who have severity of hearing loss, so a mild loss, for example, compared to a moderate loss or a severe or profound loss. But we're not actually able to understand how in an individual, how changing hearing over time is associated maybe with changing cognitive function down the line. So for that, we would need repeated measures. So one of the goals of the Cochlear Center, we're really trying to help support researchers who are interested in incorporating hearing into their studies, but don't kind of know how it's measured or what they need in order to measure it. So we have an entire core, our audiology core, that is dedicated to that. So we're starting to get hearing into more studies. And so hopefully we'll start to have some of those repeated measures that we can look. I will say when we're able to look just, hearing measured at one point in time, we do tend to see a dose response. So people who have a moderate loss, that's associated with a much stronger risk of dementia or cognitive decline compared to a mild loss generally.
Looks like Jerry had another question in the chat too.
Thank you.
To what extent do you think that health literacy could be a variable affecting results of cognitive testing? Is health literacy accounted for in ERIC?
That is a really great question. So certainly in terms of when we're measuring, especially cognition at one point in time, we really have to worry. There's a lot of psychosocial factors. Health literacy certainly could be one of them that potentially could, impact that measurement at one point in time. I think we're less concerned when we look over time because then we're able to look at trajectories within an individual. I will say in ERIC we're lucky that we do have a measure of health literacy. So we have the wide range achievement test. And so particularly anytime that we're looking for cross-sectional associations with cognition, that is one of the adjustment factors that we use. Thank you for that question.
Maybe I'll just ask one more.
Okay.
So I do use some cognitive testing, but I'm not a cognitive neuroscientist. Cognitive fatigue seems to be an influential factor. If all of your batteries are listed in the same way and trail B is at the very end, is cognitive fatigue a factor? And maybe is that an actual measure to look at in people with sensory loss?
Yeah, I think it probably is. So particularly in our study, so the two tests that were pen and paper where we found a greater prevalence of missingness associated with hearing loss, they were two kind of lengthy tests and tough tests, and they both came towards the end. So the Boston naming test and the trail making test part B. And the trails B had the most missingness overall of any of the tests, regardless of hearing loss status. It was, I think, 17%. So certainly, I think among those who have maybe some impairment where they are working harder already to kind of get through the battery, fatigue is playing a role. And then I think probably that the fatigue from cognitive load could be on top of that. So certainly with hearing loss, we know if your brain is working that much harder to decode that signal, by the time you get to the end, it may just be too much. And that's probably playing a role. I'll say anecdotally, colleagues I know who have sensory impairments say this is absolutely the case, but they have figured out ways to try to get around that in their everyday lives for compensating. So I do think it's likely playing a role. Yeah.
So if it is cognitive load, can it be like a test retest of using a hearing aid device and not, or?
Yeah, interesting. I don't know. So if you have amplification, that should help relieve some of the cognitive load. It may not relieve everything. So hearing aids, are different than glasses. So glasses, when you get a new prescription, you put them on your face, you may get a little bit of a headache. Your brain takes a little while to adjust depending on how big of a change, but then your vision is kind of restored to normal. And with hearing aids, depending on the severity of the hearing loss, that's not the case. And there's anecdotal evidence suggesting that the longer you wait to get hearing aids, the more kind of neural circuitry that has been rerouted, it makes it harder to kind of learn to use those hearing aids. So certainly amplification can help reduce some of that cognitive load. It may not reduce all of it, but it certainly might be able to.
Very interesting. Thank you.
Thank you.
Well, in respect of your time, I don't see any other questions. So thank you so much for this seminar. It was amazing. We all learned a lot of information. And then for everybody in the audience, please remember we'll resume in February for our next section on modifiable risk factors of Alzheimer's disease and related dementias, where we'll hear from Dr. DiPrieto from GW and then Dr. Erickson from Pittsburgh. And then check out our website at brainhealth.gwu.edu, and please follow us on Twitter too. So thank you very much, Dr. Deal. We very much appreciate it.
Thank you. It was great. I really appreciate the invitation. Thank you.